Over the last 20 years, endoscopic sinus surgery has come a long way. It's become more meticulous, and technological advances have markedly improved endoscopic capabilities. Further developments on the horizon promise to further expand the surgical potential. But what does this mean for patient care? Well, on today's show, we'll be looking at the future trends in sinus surgery. This is EUFOREA News, broadcasting from London. Hello and welcome to EUFOREA News. I'm Dr. David Bull. Sinus surgery has seen significant changes over the years with advancements in instruments, endoscopes and imaging. Over the last 10 years, there has been an increase in endoscopic surgeries by over 20% and a similar decrease in open surgeries. But what is the future for sinus surgery and what are the emerging trends? Endoscopic sinus surgery is a procedure used to remove diseased sinus tissue and open up the paranasal sinus cavities. Sinus disease may cause facial pain, nasal blockage, drainage problems, recurrent infections, impaired breathing and loss of smell. So, sinus surgery can therefore be used to relieve symptoms associated with sinusitis and nasal polyps, nasal congestion, nasal obstruction, recurrent or chronic sinus infections and nasal tumours. This procedure is designed to improve the drainage of the sinuses and to improve airflow through the nose, reducing the number and severity of exacerbations, improving sinusitis symptoms, and improving airflow through the nose, improving the patient's sense of smell. Well, joining me now from the United Kingdom is Mr. Simon Gane. He is a consultant ENT surgeon at the Royal National Throat, Nose and Ear Hospital and ENT surgeon to Moorfields Eye Hospital in London. He has specialist interest in surgery of the nose, sinuses and anterior skull base, nasal inflammatory disease, vasculitis and hereditary hemorrhagic telangiectasia. Simon, very, very good to see you. Let's start at the beginning. Sinus surgery, well, it's come a long way, hasn't it?
It certainly has. I mean, just in the last sort of 30 years, we've gone from the only way to access the sinuses as being to make a big cut on the face to get in, to the endoscopic revolution, where now almost all of our surgery is done via the keyhole surgery, as it's come to be known, sort of an endoscope through the nose or through the nostril, and very seldom do we have to put cuts anywhere else on the face. And this has opened up a wide range of opportunities, more controlled surgery, more precise access to the whole of the front of the base of the skull and the nose and paranasal sinuses, as well as the nasopharynx, and indeed the orbit and the brain as well sometimes. So a lot of advances, and hopefully we're seeing a lot more.
I mean, it really is quite extraordinary. So tell me, as a clinician, which patients do you decide to operate on and which do you deem or say too complicated or indeed too risky?
So that's a very broad question, because if we're talking about sinus surgery in general, sort of my bread and butter, it's more a technique for getting to places within the mid-face and the front of the head. And then you have to think, well, there are a lot of diseases that affect these areas. So how do you decide what surgery to do? It depends on the disease. It depends, as always in surgery, on the risks and the benefits. What is the natural progression of the disease? What are we going to have to do about it? And what is the morbidity from the surgery? How high a price is my patient going to have to pay, or higher risk is my patient going to have to run for the benefits that I'm hoping to provide? So, I mean, some people are just very unwell, and giving them a general anesthetic is a very high risk procedure. And those patients, you'd only really reserve sinus surgery for cases which are life and death. If we don't take this tumor out, for instance, then the patient will not have a good outcome. So it's worth taking that risk. However, if they've just had a little bend in the septum, then you wouldn't do that operation. And so it really comes down to assessing the patient in front of you, trying to balance the risks and the benefits, of your intervention and a knowledge of the disease that you're talking about and its natural progression.
So just looking at your, say, daily or indeed weekly caseload, what makes up the majority of the surgery that you perform?
So for me, I'm very lucky. I have a mix of cases from the relatively small, precise cases like endoscopic dacrocystorhinostomy for patients with excessive tearing, epiphora, which is very successfully performed what's called endonasally, and that I would do in conjunction with my colleagues at Moorfields Eye Hospital. To I have a large cohort of patients who have a disease called hereditary hemorrhagic telangiectasia, where they require laser surgery or other more advanced techniques, which are often performed with the endoscope. And then a large portion of the rest of my patients have nasal inflammatory disease, usually chronic rhinosinusitis with nasal polyposis. And yeah, they're sort of the big three for me at the moment.
So I assume, I mean, you're an expert in this field, but I assume you are learning all the time. How does that work for you? Are there things that determine your success? Do you then look at patients differently? Can you always tell which patients will have really good outcomes?
Oh, I wish. If we always knew who was going to get the really good outcome, then we would just not do the patients who were not going to get a good outcome. But unfortunately, and this is what, I mean, as much as we like to pretend that surgery is a science, and there's certainly a lot of science that goes into it, there is an art to it in that it's a very complex field full of complicated and chaotic interactions that you have to try and predict and avoid if possible, or minimize before you get on to providing those results that you'd like to provide to the patients. So it's not always easy. I think as you get more experienced, it becomes maybe not easier, but you have a better grasp on the requirements of your patients and the demands that your surgery will place on them, and the demands that the disease will place on your surgery. And so there's a little bit of sort of what I always refer to as innate learning in that experience, but learning from my colleagues, learning from my trainees, learning from textbooks, learning from conferences, that all goes into the stew to try and rebalance my sort of probabilistic approach to what I'm doing for my patients. And you're right, it's an ongoing process. And I think if you stop learning in anything in medicine, then you start to run into trouble.
Yeah, very well said indeed. I assume also, as you've practiced more and more, indeed, as you take on that bulk of evidence and you have more experience, it's also about timing the surgery, I assume, for each patient, making sure it's at the right time.
Absolutely. I mean, so for instance, if we're talking about chronic rhinosinusitis with nasal polyposis, we know that there are some biomarkers we can do to check what the likely response is from those patients to our surgery. We know that, for instance, if they have a high eosinophil count, they're more likely to need more operations, and you want to try and time that accordingly, try and minimize the amount of time that they are with symptoms, but also try and minimize the number of operations they have. And that trade-off can be quite complex for most severe patients. That said, patients with CRS with nasal polyposis, we know that surgery has an impact down the line on things that as ENT surgeons we may not even consider. For instance, early intervention with functional endoscopic sinus surgery, debulking this inflammatory mass that is a polyp, has been shown over and over again to impact on asthma control and systemic symptoms, including mental health. So being cognizant of that, knowing that your surgery is going to impact properly, and trying to grade response, severity, and the need for further treatments down the line is all part of what goes into the mix of timing these operations.
So right at the beginning of the interview, you talked about how things have progressed. The fact is you no longer really do open surgery. So just in terms of the latest trends in sinus surgery, what do you see evolving? How do you see it evolving from here?
So the latest trends. I mean, there is now a trend towards minimally invasive local anesthetic office-based approaches with balloons, with dilating the sinuses rather than performing a general anesthetic endoscopic approach. I think we will find that they have it's still in very early stages, and the evidence base is not that strong. I think we will find that they have a place in the management of certain conditions, but you can imagine that dilating a sinus is not going to help a nose that's full of polyposis. So they won't be the panacea for all sinus conditions. In the future, two trends that I see impacting on sinus surgery in general is the advent of the biologics in CRS. So these are new drugs with quite a range of them now that impact the inflammatory cascade of this disease within the nose and indeed within the body of the patient. And the interaction between them and sinus surgery is something we really are going to have to work out in the next 5 years. What is their place? Are they a primary therapeutic option? Are they secondary to surgery, i.e. do the surgery and then use them as an adjunctive preventative treatment? Or do they only have a place in certain cases? And that will depend, as is so much, about the money, the funding, the healthcare system that they're being used in, all of those things. And if I can just say one other really interesting trend that we're not seeing so much in sinus surgery at the moment, but I have high hopes for, which is robotic surgery. At the moment, the robots are big and clunky, and you require quite big ports. But when and if the development of these single port, narrow port robots is successful, then that's going to open up a whole range of opportunities for going around corners that we can't go around essentially before. So I think that's in the further future, and something I'm quite excited by.
And just finally, if I may just ask on a personal note, this must be incredibly rewarding for you, seeing patients getting better, getting their symptoms under control. It really must be a great job.
I mean, I think so. And maybe most people might not think so. It's not like most jobs. It's not without its stresses. Things don't always go according to plan. Patients aren't always massively better, although fortunately, the surgery and the conditions I deal with, that is seldom the case. But it is very rewarding. I had a very complex case only yesterday. In fact, it was very complicated, required 4 consultant surgeons, or 5 to get involved. It took all day, lots and lots of surgery. And it was just the feeling at the end when you know the patient's going to get much, much better improvement, quality of life, risk for their ongoing life, those kind of things. You know it's going to get better. I remember thinking in the operation yesterday, which happens to be more than I'd like to admit sometimes. I just love doing this. This is just what I want to do, which I recognise is a rare gift sometimes.
Well, amazing stuff. Thank you so much for joining me, Mr. Simon Gane.
Thank you very much for having me.
Well, that's it for this EUFOREA News Show. Many thanks indeed to my guest, to Mr. Simon Gane, for a really fascinating and informative interview. Now you can find more information about EUFOREA and also register for the EUFOREA meetings on the euphorea.eu website, where you can also sign up to receive our latest news via email. Our Twitter address is @EUFOREA. Until next time, goodbye.